Good evening, everyone. Thank you for coming along this evening. I'd like to start by acknowledging the traditional and original owners of the land on which we meet, the Muwinina people, and acknowledge elders past, present and emerging. I'm John Stubley. I'm the interim CEO of the Royal Hobart Hospital Research Foundation. I've got notes to make sure I don't forget anything, but I don't usually follow them anyway. The Royal Hobart Hospital Research Foundation is an independent organisation that raises funds for medical research in Tasmania. So we fund about $650,000 a year of medical research. We invite researchers to come forward with their ideas for grant funding, and we have a group of medical specialists who review those grant applications and determine which of those research projects warrant funding. If we get more research applications that warrant funding than we've actually allowed funding for, we will fund more. Some of the grants we fund are small grants, and those are for new ideas, something that someone's thought of that maybe no one else has thought of. Because I guess, like a lot of things, if you don't explore what you don't know, you won't find out what you don't yet know. So that's all part of the process. Where are we? And I'd like to thank St Lukes for making this room available for us tonight, their wellness hub. St Lukes, like the Research Foundation, have people's health concerns at their heart, and it's a logical partnership for us to work with them to run this event. It's great to see so many people here who are interested in finding out more about health issues that affect, no doubt, a lot of people in the room and a lot of Tasmanians. Obviously, I guess it's not obvious, the funding that we raise in Tasmania goes to fund medical research in Tasmania, and we're fortunate to have essentially one hospital, one major hospital, and one resident university in the state, which makes for a good collaboration around research, which I think puts us in a bit of a unique position compared to other states. That's probably all I need to say for now. I'll hand over to Brodie to introduce our speakers and to MC the evening. Thank you.
Thank you, John. All right, well, thanks for that welcome. As John said, my name's Brodie. I'm from the Research Foundation, and I'll be facilitating the event tonight. Pain is a complex condition and often quite debilitating, and it affects many Tasmanians. Chronic pain in particular can significantly impact the quality of life, making daily tasks quite challenging and reducing the overall well-being of many Tasmanians. Tonight we have gathered to an expert panel to shed light on this pressing issue. Our discussion tonight will delve into the complexities of pain management, exploring the benefits and limitations of medications, and the potential of novel treatments like cannabis. We'll also be exploring the importance of physiotherapy and movement in managing pain. Now, before we begin, I'd like to introduce you to our special guests, and they've dedicated their careers to advancing our understanding of pain and treatment, in the treatment of pain. Their research and clinical work are making significant strides in combating this condition and offering hope to improved care for many Tasmanians. So firstly, we've got distinguished Professor Gregory Peterson. He's an experienced researcher and practicing pharmacist who will discuss the benefits and limitations of medications and novel ways to use cannabis for pain management. Next, we've got Dawn Aitken, who will focus on physio and movement to minimise pain and improve health outcomes, providing a holistic perspective on pain management. Sorry, I got a little bit tripped up there. My tongue was moving too fast. Next, we're honoured to have Felicity Veal, an academic and educator whose research into opioids and paracetamol toxicity provides critical insights into the pharmacological management of pain. Wow, that's a big word. Anyway, I got there in the end. All right, so let's dive into some questions. First up, Dawn, what are the different types of pain that people might experience?
Thanks, Brodie. Can everyone hear me? Yeah. So, as you probably are aware, there's many different types of pain. One of the most common types that we talk about is mechanical or nociceptive pain. And this is pain that can come from an injury, for example. So if you were to roll your ankle might be sore, there might be some swelling and inflammation. And we would call this mechanical or nociceptive pain that is sending pain signals to our brain. Just some terms that we're going to talk about tonight. We're going to be talking about acute pain and chronic pain. When we're talking about acute pain, we are really talking about that pain that comes from, say, an injury or from surgery. Acute pain usually infers that it's short-term pain and that it should resolve when your tissues are healed. But sometimes acute pain can persist and become chronic pain. And we generally say that this happens if pain lasts longer than 3 to 6 months or longer than the normal healing time for a tissue. So another type of nerve pain that is quite common, and another type of pain is called nerve pain, also called neuralgia or neuropathic pain. And this is pain that comes from our nervous system and from the nerves within our body and can be related to a number of conditions, which Felicity will talk more about. Another type of pain that we're starting to really learn a lot more about and be able to treat better is nociplastic or neuroplastic pain. And this is actually pain that we feel in our body, but is not coming from any damaged tissues. Our pain system is very good at protecting us, and that's what it's trying to do. And sometimes our system can become oversensitive or hypervigilant or overprotective, and it can send signals that make a person feel pain when there's not actually an injury there. That type of pain can also be referred to as central sensitization. So that's just a very broad overview of some of the different types of pain and some of the terms we'll be using tonight.
Wow, okay, didn't know your body did that to you. Kind of cruel almost. Okay, Felicity, what are some of the conditions or events that can result in persistent pain that you've encountered in your practice or research?
Hopefully everyone can hear me too. So I think just going on from what Dawn was saying, we obviously have some types that we don't know what causes the pain. We're not actually sure what the trigger is or what event triggered it. Then we have other types like musculoskeletal pain, so back pain, osteoporosis related pain, so when you have fractures over time it can result in pain. Inflammatory arthritis, so rheumatoid arthritis, juvenile polyarthritis. You can also get pain from fractures that can obviously persist a long time. Then there's pain from things like neurodegenerative disease. Speak it up, sorry. Neurodegenerative disease as well, so things like multiple sclerosis and Parkinson's disease can also result in a lot of pain. Neuropathic pain, so that can be, for example, after a stroke or associated with diabetes, so peripheral neuropathy. And then we can have things like headaches, chronic migraine, and also cancer, which whether or not it's caused by the cancer itself or the treatment for cancer can cause pain long term as well. And probably one of the other things to consider is events and things like injuries that you have, such as workplace injuries, mechanical injuries that can persist, but also surgery. So depending on the type of surgery that you have, anywhere between 20 and 80% of people will have that pain persisting beyond the time that they had the surgery, and it will actually be the surgery being the cause of the pain. So a little bit dependent on the type of surgery, but that's also quite a common cause.
Great. Thanks, Felicity. Now, Gregory, do factors interplay in the development of chronic pain or persistent pain, and are there any characteristics of pain that are worth noting?
Thanks, Brodie. So we're focusing now on the chronic pain, and this is this difficult transition where people have acute pain and some individuals develop a chronic pain condition. And I guess one of the things, and you've mentioned already tonight, Brodie, and it'll be part of the answer again, is that pain is complex. It's very complex, it's very individualised, it's multifactorial, and that's one of the reasons why it's difficult to treat because of that. In terms of chronic pain development, sometimes there's nerve damage. There may be, following shingles for instance, or following a back injury, there may be some residual nerve damage which leads to the neuralgic pain that Dawn mentioned, the nerve pain, neuralgic shooting type pain. So that's sometimes an explanation. Sometimes we blame it on what Dawn also mentioned, the central sensitisation phenomenon, where in some individuals, the brain, the central nervous system seems to change to an extent in terms of pain impulses being amplified as they reach the brain. So in some individuals, for whatever reason, there's this amplification of any pain stimulus, and they can develop chronic pain. Perhaps the key thing to mention at this point, though, is what we call the biopsychosocial framework. It's a mouthful again, of pain, and I'll mention that because it's often used these days to explain pain and its development and how individuals experience pain differently. It's also used as a framework for how to manage pain. So if I just briefly allude to it, and I'm sure it'll come up again, biopsychosocial, so 3 components. Bio first is the biological or biomedical factors, so the tissue, the damage itself, the condition, but also other conditions the patient or the person may have, their general frailty, their general health, etc., are important in determining response to pain and perhaps developing chronic pain. Psychological factors, the second one, the psychological factors. That can include things like resilience and tolerance and adaptive capacity to handle pain, but also can include things like other mental health conditions, so they can have an impact. The third one are social factors, so even isolation, loneliness, partnerships and so on can have an influence. So what we talk a lot about these days is pain and its experience is influenced by the combination of those into a framework. And chronic pain may develop in some individuals because of the interplay of those factors. And we'll come back to how we manage pain or should manage pain, because we need to also tackle each of those aspects to do it successfully. So we might leave it there. It's a short version, it's complex.
Yeah. Wow, thank you very much, Gregory. That was...
A bit too complex?
No, it was great. Thank you very much. Very informative. All right, over to Dawn. How would a patient currently be assessed for chronic pain? And is it an invasive process?
Yeah, so that's a really good question. Assessment of chronic pain should include involving a health professional, so a patient talking to a health professional or a clinician about the pain that they're experiencing. And usually there's a long journey or process of talking, of getting a full history of the type of pain that person's experiencing, where they feel it, how long it's been going on, how it may vary from day to day, and how much it's impacting on their life and their disability. So it's usually a process of you as a patient explaining to the health professional what you're experiencing. And then the health professional will want to use that information to try to understand what type of pain you are experiencing, whether that there could be an acute component to it, whether there could be a mechanical or something wrong with the tissues. And they'll look at the other factors that Greg spoke about as well. And it doesn't have to be an invasive process. It really depends on which health professional you may go to seek information about your pain. Some clinicians or doctors will want to use scans or blood tests to try to understand it more, and that can be helpful. And in some ways, those are tools that are in a toolbox to help understand the pain process for each individual. But it's also important to note that what we see on a scan, so what we see on an X-ray or an MRI, doesn't always correlate with the level of pain that people are experiencing. And unfortunately, we don't have a scan for pain, so it really relies on the person to be able to explain their experience and really tell their personal story to people who specialize in pain management.
Okay, thanks, Dawn. Back to you, Fitzgerald and Gregory. Can you share any insights into the importance of early diagnosis in the management of acute pain to prevent it becoming a chronic pain diagnosis?
Sure. And Fee might cover this as well, so I'll try
I
not
think I'm
not to cover everything, but most of the evidence comes from the surgical space, Brody, where we know, unfortunately, a reasonable proportion of patients will develop chronic pain following surgery, following acute pain, and so that will develop and persist for longer than 3 to 6 months, as Dawn said, become chronic pain. So we know a fair bit about that, and we try and translate that evidence to other types of acute injury, etc. So what we do know and what happens now to a large extent at most of our hospitals is there's a lot of work preoperatively into that to try and prevent that. So education of patients in terms of expectations about pain, how to manage pain, use of patient-controlled analgesia, which you may have experienced yourself following surgery. So really trying to address pain management acutely well following the surgery. That's critical. That we know that is critical, being on top of the pain. But a fair extent of that does involve patient education in terms of anticipation, their expectations following the surgery. Using things like patient-controlled analgesia well, then getting patients mobile, active, etc. as soon as possible. As well these days, of course, as using less invasive surgeries when possible, so laparoscopic type surgery rather than the older open type surgeries. So all those things are done reasonably well these days. Most hospitals also, the Royal Hobart as an example, has a pain management team that goes round the wards, sees patients, will try and ensure that the pain management acutely is perfect. So there's a big emphasis on getting the pain management acutely perfect, because that seems to lessen that risk that we talked about of the central sensitisation, where you get changes occurring in perhaps the spinal cord and the brain, where pain impulses become amplified and people may go on to develop chronic pain. So that acute phase of management is critical.
Wow. Okay, thank you. Now, Felicity, we were having a good bit of a chat about this last week. Now, is there any bias in the assessment and diagnostic process?
I wish I could say that there isn't bias, but unfortunately, like with most things in life, we all have biases that we bring in, and so do practitioners. So alluding back to what Dawn was talking about, if you can't articulate your pain experience, it's very hard to get a diagnosis. So looking particularly in paediatric populations, especially young children, they don't comprehend or be able to have the vocabulary to be able to articulate their pain. So we know that it is often underestimated, and most of it goes reported by parents of, that it just appears that they're in pain. We don't have anything better to go by. And so younger children are definitely at risk. But at the other end of the spectrum, those with neurodegenerative disease, so dementia and other areas where they are unable to communicate anymore, we also know have problems. So if you can't communicate your pain and you're non-verbal, it's very hard to get that across and then get appropriate diagnosis for new acute pain or treatment. So especially, and both Greg and I have worked extensively looking at aged care facility pain management. If you're on an as required pain management, so if the patient seems to be in pain, they'll get it, you're much less likely to if you're non-verbal. And in aged care especially, we also find if you're hearing impaired, you're less likely to get pain relief too. Whether that be that you're not necessarily able to hear and respond to questions about pain, or if it's a different reason, we're not quite sure, but we do know that association is there. Two other groups where bias often occurs is minorities. So, for example, there's been extensive studies in America done that have found biases and, what was the word? I just want to make sure I get it right, was false opinions about minorities. So, for example, black people in America, a lot of physicians thought they had thicker skin and less likely to respond to pain than white people. So they were automatically given less pain relief and less likely to be listened to. The same can be said for women across the world as well. So if you go into an Australian hospital with abdominal pain as a female, you are less likely to get analgesia than if a male presents with the same issue. So we know some of this comes from bias. You know, males are stoic. If they're complaining of pain, it must be legitimate. Women can be dramatic. You know, we also know, and I mean, over the last few years, people have been coming out around endometriosis and the need for improved management of women's healthcare. And a lot of this has come, well, it's just part of your normal cycle. You'll be fine. It's not real pain. You know, just suck it up and deal with it. And so there's been this real change recently, but that bias is still there. So it's really about advocating for yourself as a patient who has pain to make sure that you are listened to as well. Because if you don't necessarily find that someone's listening to you, you know, you always have alternative practitioners. So I guess that's probably one of the things to think about with cognitive bias. Hopefully that answers that.
Thank you so much, Felicity. That's really important and also sad to hear. So thanks for bringing that up for us. All right, so let's move into treatment. Felicity, we'll stay with you for this one. So what are the current treatment strategies for chronic or persistent pain, and how personalised are they?
So going back to the biopsychosocial model that Greg was talking about earlier, it really is a three-pronged approach. So we want to deal with your ability to psychologically manage the pain and also work out whether or not there are any triggers in your past that might be something to consider. We want to also look at the physical component, so physiotherapy, making sure that you have, you know, ability to rehabilitate, build muscle strength, things like that. And then we have the pharmacological management. As a pharmacist, obviously that's where most of my time is spent. I think the drug companies really got it wrong when they called it drug, you know, these are painkillers. I think most of you, if anyone's taken a pain reliever recently, unless it's an acute headache, it's probably not killed your pain. It's probably still there. And so whilst we try very much to go by guidelines, as we talked about before, pain can be caused by so many different things. It's a bit hard to treat based on a guideline of what was in a trial. And we'll talk later about trials and evidence and how that doesn't necessarily work in pharmacological treatment of pain. But we have guidelines, we try and follow them, but we definitely don't individualise pain as much as we should. You know, what one person suffers isn't going to be what the next person suffers, and similarly, one person's response to an analgesic isn't going to necessarily be the next person's. So we very much need to work further towards individualised and personalised pain management, but we're not there yet. Did you want me to cover drugs, or are you happy with just... Yeah, Greg's like, I should keep talking. So I guess most of you, if you experience pain or if you've gone to a pharmacy, you've got your paracetamols, your ibuprofens, all of your anti-inflammatories. So these non-opioid analgesics are our first step. They're the things we try first because they're safest. We think they, you know, and there is evidence to some degree for all of these products. If that doesn't work, we then step onto opioids, so the next step up. And they can work really effectively in some people, and they really don't work in other people. For people who have nerve pain or neuropathic pain, we also have something called adjuvants. So these are medications that are not strictly pain relievers, but they work to help reduce some of those pain signals, and especially in neuropathic pain, are more likely to work. So these are things like pregabalin or gabapentin. In addition to that, we have a whole host of other pharmacological management strategies that kind of step up further, but they're very much specialised to the pain specialists and generally not all that common to see.
Thank you, Felicity. All right, Greg, in your experience, what has been the most significant advancement in pain management in recent years?
Okay, this won't be very exciting, I don't think. We can come back and talk briefly about things like, there's a lot of research happening, stem cell therapy. We can talk a little bit about that later maybe, to try and regenerate worn discs and damaged nerves. So particularly for neuropathy or nerve pain. There's a lot of work going on with stem cells. There's a lot of work going on with things like neuromodulation, which is nerve stimulation type techniques. So there's a lot of research that is happening. It's not quite to the clinic yet. So less exciting, but far more important is perhaps using what we have already in a better way, and this comes back to what we've already discussed. The biggest advances has really been multidisciplinary care and multimodal analgesic therapy. So firstly, multimodal analgesic therapy Fee alluded to, that's using analgesic drugs that have different modes of action, different effects in combination. They complement each other. Some are better for nerve pain, some might be better for inflammation, particularly lessening the reliance on opioids, which we know have problems. We've seen the federal government in 2020, I think it was from memory, bring in restrictions, tighten up restrictions with opioids for good reason generally. So using combination multimodal analgesics, that's changed quite markedly for the better. Secondly, coupled to that, very much related to that, is multidisciplinary care teams to manage pain. So this is having the GP, pain specialist, physios, exercise physiologists, psychologists, social workers, working together as a team, holistic team, with the individual. And it gets back to, again, tackling that biopsychosocial model. So addressing each of the elements of that framework and doing that together. We should acknowledge, we haven't acknowledged today, this is National Pain Week. You've perhaps seen some of the media related to that. And so there's been surveys, and the ABC and other media have talked about some of the results of those surveys. So one of the findings was that, unfortunately, only about 1 in 100, one of the problems is access to those. Dawn will cover this shortly, Dawn is trying to address that in part, trying to improve access to those multidisciplinary teams of care. So that National Pain Week survey showed that only about 1 in 100 Australians have access, unfortunately. That's particularly problematic in rural, remote areas, to get the allied health workers and the GPs, etc., all together to work with the individual. But that really has a massive impact because they can address simultaneously that all the elements that we know impact on the pain experience. So that really has been the biggest breakthrough or advance, that understanding of how critical it is. It's how we do it is the problem. The system isn't well geared to do it at present, unfortunately.
Wow, thanks, Greg. Over to you, Dawn, if you want to probably elaborate on what Greg just finished on. So obviously, there are significant limitations on analgesics and opioids. What are the best long-term solutions for people with chronic pain?
Yeah, so a lot of my work is in osteoarthritis. And so I have a focus on knee and hip pain. And I suppose from that perspective, we know that analgesics or pain medications don't work that well. So paracetamol or an NSAID, an anti-inflammatory, will have a very small effect on people's pain. So if it was a scale from 0 to 10, it might only reduce your pain by 1 unit out of 10, which is quite small. And given that a lot of analgesics have side effects, and there's many people that can't take them, it's really important to sort of acknowledge that they are only one bit of management in our toolbox, and there are other things that really should be considered before analgesics. And so one of the things I wanted to say was that we know that the gold standard treatment for chronic pain is multidisciplinary care. And Greg's outlined what that looks like. But currently access is quite poor. So it's difficult to get access to allied health professionals, psychologists, social workers, and there are major bottlenecks in our hospital systems that have, working pain units, but getting people into those units to receive the care they need is the problem right now. So as Greg said, one of the big aims and sort of messages to come out of Pain Week is lobbying state and federal governments to try to improve primary care services for people with chronic pain. Because these models of care that they have, where a patient gets to work with that variety of health professionals, really is the most effective way to manage pain and have it improve over time, and for some people even go away completely.
Wow. Well, we can hope that it starts to improve over the next few years. Looking ahead, actually, it's a great segue. What promising research or technologies do you believe will shape the future of pain management?
Yeah, so I think we have covered this a lot, and I had written down here that there is no silver bullet, and that it's really about personalised treatment, and it's very unique. So there's not going to be a one-size-fits-all for everybody, and for those that have pain or are experiencing pain or have a loved one who is, sort of being understanding and empathetic that what works for one person might not work for the next. And that's why that team is really required to put the puzzle pieces together for that person, so that that person can create goals, start doing things in their life again in which their pain might have been impacting. So in terms of promising research and technologies, I would say that's really us trying to advocate for better primary care services.
All right, and Felicity, over to you. What unique challenges and opportunities do you see for managing chronic pain in Tasmania, particularly in rural and remote areas, and how can we leverage on our local resources and expertise to address these challenges?
I think it's $1 million question, isn't it?
Easy one.
Yeah, absolutely. I can just fix everything. We're fine.
Yeah.
Look, I wish it was that easy. As we alluded to, access is a big issue. It is very easy to get a script off the PBS from your doctor. Takes, not long to write and it's out. And then it's all subsidised. It counts towards your safety net. If you need physio or if you need psychology management, if you want to go through the private system, so not through a multidisciplinary program, you have access to around 5 appointments a year with a physio. I'm sure Dawn will allude to it. That's not going to get us very far. And so until the models of funding change to increase the amount of funding that we have for allied healthcare professionals on the MBS, so being able to be funded so that it is subsidised to some degree, we're probably not going to get very far. Drugs are not painkillers. They may help reduce the pain, but at the end of the day, we really need to move away from the aim that we're trying to reduce your pain to we're trying to improve your ability to function. We're trying to make sure that you can go to the grandchild's appointment, you can, run around with them if you want to, you can go to school and see what they're doing in assembly, you can do the job you want to do, spend time in the garden. Pain relief might help you do that, but a lot of the other things are needed for that real change in that quality of life to make it worthwhile. I think the other thing that's going for Tasmania is we have an ageing population. 20% of people in the world have chronic pain, and that increases with age. So we have more and more people needing access to multidisciplinary clinics, and we only now have 2. We do have one now in the northwest, which is exciting, after them having to previously come all the way to Hobart. But it's still 2 for 20% of the population, so it's definitely not making it stack up. We do have projects, there's one from the hospital, from the pain clinic called Project Echo, which they were running where the pain team were actually educating GPs and other healthcare professionals all around Tasmania, trying to echo their skills into primary care. And things like that definitely help because you've got GPs interested in wanting to engage in this, and we have this ability to be able to do that. So that's been one great new thing that we've been able to get up and running in Tassie. Not me personally, but the pain clinic. And I think the other pain clinic, but we're so far away from an answer of how we're going to fix this. I think advocacy is probably the best option we have at this point to try and get better funding for allied health.
Wow, thanks, Felicity. And now, Greg, what alternative pain management strategies do you foresee gaining prominence in clinical practice over the next few years? And how can these alternatives be effectively implemented to ensure patient safety?
Thanks, Brodie. Just leading on from Fee, first of all, I think the multidisciplinary care team work will increase. Well, I'm hopeful it will, but I think it will as well. Minister Butler has announced, you would have been aware perhaps of the Strengthening Medicare Task Force, the Strengthening Medicare report from last year now. The federal government, well, they've made a commitment at least to strengthen Medicare and strengthen primary care. And a lot of that is about multidisciplinary practices. So having general practices where allied health professionals are part of that practice or come into that practice frequently. So the federal government has that as a goal. How quickly they do that, how quickly they fund it, I'm not sure, but so it's a stated goal, and that'll help overcome to some extent the issues that Fee mentioned when we strengthen Medicare. we should acknowledge, just briefly, perhaps there have been advances, quite a few advances in areas, some of the conditions that often cause pain, not so much osteoarthritis, but rheumatoid arthritis. So we have the monoclonal antibody drugs now. Some of you may be familiar with some of these. They're expensive, but they're on the PBS, they're PBS covered. So we have drugs now that slow some of the conditions that are commonly associated with chronic pain. So particularly in rheumatoid arthritis, multiple sclerosis, which can often have spasticity and pain associated with it. We have drugs now, also monoclonal antibodies that can help slow the progress of MS. And some of the chronic intestinal disorders, which can also be associated with pain. So there have been some great advances for some of the conditions associated with pain. In terms of what's happening, I won't go into a lot of detail. I'll briefly mention before, there's a lot of research looking at things like stem cell therapy, where in theory you could have the ability to regenerate nerves at least. That may help with nerve pain, or regenerate degenerated discs in the back, for instance. So there's a lot of research going on in that space with stem cell therapy. There's lots of research happening with, as I said before, neuromodulation, different types of stimulation, either direct stimulation to the brain or nerve stimulation. So there's lots of things happening, not quite there yet. I think the biggest thing at the moment still is the multidisciplinary care involving the individual, empowering the individual to be more involved, take greater ownership, etc. Fee's alluded to this. The goals may not be so much pain-free as being able to function, etc. It might be a nice segue into cannabis, though, perhaps, if you want to go into that space.
Yeah, so your research provides some significant insights into the benefits and limitations of cannabis for pain management. Could you elaborate on how this is influencing pain management practices in Tasmania?
Perhaps less so in Tasmania. So I should say I was on a panel for the Veterans Affairs for a number of years. I was on a small panel for the DVA, Veterans Affairs, where we looked at and approved funding of medicinal cannabis for some veterans. We were fairly strict with the requirements because the evidence is the problem here. There's not a lot of evidence for a number of conditions. There is evidence for some rare childhood epilepsies. There's very good evidence for, there's products available for multiple sclerosis, spasticity. Neuropathic or nerve pain is perhaps where the evidence is best in the pain area, so specifically for that nerve pain, not so much for other types of pain. And we certainly funded a number of individuals, and this is the trouble again, it's anecdotal evidence where a number of those individuals were able to reduce their opioids, etc., and did benefit. But this is a common problem. There's not a lot of high quality evidence, and you've probably read this yourself. Not so much of what we call the randomised clinical trials, which look at cannabis in treatment of pain. A lot of it is more observational and reports. The National Pain Survey again this week, so it said it was about 30% had accessed medicinal cannabis. So 30% had tried prescribed medicinal cannabis. Just over half of those found it beneficial. So, again, it's sort of anecdotal, seems to help some, but specifically that neuropathic pain is where it may have a role. It's not a primary role, it's not a first line therapy or a second line, it's more a third or fourth line therapy. And it's not a panacea, even by that data that I just mentioned, only about 50% at best might have some benefit. It's expensive, so there's issues there. I should briefly say there's two major components. When we talk about medicinal cannabis, there's a number of components, but there's two main components. There's THC, if you've heard of that, tetrahydrocannabinol, which is the bit that causes the highs, etc., which is why people sort of misuse cannabis for the THC bit. There's also CBD, cannabidiol, which doesn't have those effects. So in pain management, what we try and do is use CBD on its own, if possible, adding the THC if needed, for instance, to help the patient sleep at night. So often patients can be managed with cannabidiol alone several times a day. They might have a formulation with tetrahydrocannabinol added at night time. So we know how you have to start slow, you go slow and increase slowly. There are some side effects, although probably less than most of the other analgesic drugs if you do it properly. You get dry mouth, you can get some dizziness perhaps and some drowsiness, particularly if you're taking the THC component. You can get anxiety as well from the THC component, which the CBD component helps reduce. So they're often used in combination. There's other issues. Driving is a bit of an issue. So in Tasmania, if a random, I think the legislation says if it's just a test, if it's found on a test and it's prescribed, that's okay unless you're impaired. If you're impaired, so your driving is impaired, etc., you'll still be charged for having drugs in the system. Does that make sense? But if you're not impaired and you have a prescription, you shouldn't be charged as such. But that is an issue, driving. Costly, as we said, in Tasmania, less usage. There's less GPs prescribing it in Tasmania. You have to go through a little bit of a process through both the federal government and in Tasmania through the state government to get approval. It's a two-step process, but not overly difficult, but there's not a lot of GPs prescribing it in Tasmania. So what we have, and some of you may have experienced this, what most Tasmanians are probably doing is telehealth to clinics that specialise in medicinal cannabis in other states, and the doctor there prescribes the medicinal cannabis and it's shipped to Tasmania. So it has a bit of a niche role. It's not a panacea by any means, and the evidence is still not fantastic. Felicity alluded to this though before. People sometimes pain specialists and others even question the evidence relating to any painkillers and whether conventional trials are the best way to look at pain management given that the experiences are so varied, etc. Maybe we discount people's individual experiences too much and the normal trials should carry less weight. I don't know, there's a lot of debate about that, but yeah, so it has a niche role, potentially useful in some individuals with severe nerve pain, not responding to other things. And Fee mentioned what some of those other things are, the Lyrica type drugs, the pregabalin, the gabapentin, amitriptyline, duloxetine. So if those things aren't working, etc., then it's potentially an option which may warrant consideration, but not without its downsides.
Great. All right. Well, thank you, Gregory. Over to Felicity. You did some research for the foundation into some opioids and paracetamol toxicities. It provided some insights into pain management. Could you discuss the challenges and advancements in managing pain with these medications?
So I think we've covered a lot already,
Yes,
but I think it really does come down to the evidence is a problem. So if I gather 20 people who have osteoarthritis of the knee, they're all going to have a very different experience. I'm sure Dawn can allude to that. Some people will have 10 out of 10 pain, other people will be 3 out of 10, but they're all going to be shifted into the same trial together. We're all going to give them the same drugs, but we're not going to let them have anything else, and then we're going to see how that drug works. Now, we don't treat in a single drug manner if we are going to use drugs. We tend to use a multimodal approach. We'll add things together and get them to work in different ways. When you look at clinical trial evidence for drugs, it's one drug versus placebo. We don't get the other amp, so we're not even comparing to real clinical practice. So we get very little evidence. One of the pain specialists that used to work extensively in Tassie used to say, pain is an N of 1. You can't just look at the trial data because what works for one isn't going to work for another. And I think that's where everything falls down really with pain management, is the trials are not there. Most trials last 6 weeks. All opioid trials basically have no real trials, random controlled trials, beyond about 6 weeks in duration. They're not allowed to take other medicines, so it's just not reality. So we really need to move towards individualised pain. But ideally we also need to just prevent it from happening in the first place when people are experiencing acute pain. Managing that better is really important. So one of the areas I've worked for with the foundation has been looking at post-surgical pain. What happens after you go home from that operation? You've given a ton of medications when you leave. Good luck, have fun, manage it yourself. And we know that that period is really important too. We know that when you go home from hospital to 6 weeks, if you don't get your pain management right when you're at home, you're also at higher risk. So trying to educate patients and set that expectation. Painkillers are not in fact painkillers. They are, will help relieve some pain, but they're not painkillers. So I think there's some of the things that we've found. With relation to paracetamol toxicity, which I've been doing a bit of work on recently, anyone know how paracetamol works? No, you've got 2 pharmacists up here, we can't tell you either. So it's old as the hills. You'd think we would know everything about it, right? You can buy it for $2 for 100 tablets down at the local pharmacy. Yeah, we don't actually know how it works. We have some ideas, but we don't actually know. And so this makes it really hard when we're then going through and trying to look at the safety of a drug that is used ubiquitously in society, but all of the data is extrapolated from young people. It's not actually specific to the people who take it. And so we have a lot more work to do to individualise and make sure that people are getting a dose that works for them, but without any risk of side effects. So that's what we've been working on recently, to try and actually work out this ubiquitous drug no one really wants to research because it's cheap as chips, and actually how does it work, who is it going to cause problems with, and how can I find that out? So they're kind of the areas that we're working on at the moment to individualise pain management moving forward.
Thank you, Felicity. Now, Dawn, you've prepared something earlier, haven't you?
Yes, I
So-
have. It's not a dance. It's a PowerPoint presentation.
Apparently we're fine, but I think...
So I'm just going to take a few minutes now to tell you about a program called GLAD. And GLAD stands for Good Life with Osteoarthritis from Denmark. So as you probably guessed, this program was developed in Denmark and has now expanded to 10 countries around the world, including Australia. And it's an evidence-based, standardized program for hip and knee osteoarthritis. You can take the word osteoarthritis and replace that with pain. So it's for hip and knee pain. You don't have to have an official osteoarthritis diagnosis to do this program and have a benefit. It's group-based education and exercise that goes for 6 weeks. So it's twice a week with a physiotherapist or exercise physiologist who knows a lot about treating knee and hip pain.
I'm back.
Now, there's very compelling evidence around the world and in Australia now that this program works very well. It reduces people's pain, it improves their function, improves their quality of life. If you look at people who participated in the program and ask them 3 months later how their pain is improved, but also quality of life and their function, 70% report clinically meaningful improvements in pain. And this, for some people, lasts all the way until 12 months following participation in the program. Now, what's really interesting was this program was actually first developed as a prehab program for surgery. So it was developed in people who were presenting with what clinicians would classify end-stage osteoarthritis. So the patients were having a lot of pain. It was impacting their life severely. They might have had a lot of night pain, and they also had a lot of osteoarthritis changes on their x-rays. But what they found was when they put people through this program to try and strengthen their knees and their hips to get them ready for surgery, 3 in 4 reported, no, I don't actually need the surgery anymore. This program has worked to fix, not necessarily bring me down to 0, but it's enough to delay or prevent the need for surgery. Sorry, I think there's a timer. It's telling me to go faster.
Oh, sorry.
That's okay. And So it was brought to Australia 8 years ago in 2016 by a group of Australian physiotherapists, and there's now 500 sites all around Australia that offer the GLAD program. And in Tasmania, there are 10 locations that offer the program, and these are in private physiotherapy practices. So obviously there's a cost for patients to participate in this program. And so a few years ago, my research team partnered with the GLAD Australia team and the Tasmanian Health Service with funding support from the Royal Hobart Hospital Research Foundation. And what we wanted to do was implement this program in public physiotherapy outpatient clinics in southern Tasmania. And we really wanted to know, is this a feasible and acceptable and effective program for public patients in Tasmania, in a Tasmanian healthcare setting? Oh, yeah. Yep, so the program started in May 2022, and we implemented it at 3 outpatient clinics, so in Kingston, Rosny and Glenorchy, and to date greater than 110 patients have been enrolled, and you can see the different locations there where the program's offered. So GPs can refer directly to this program. There is no cost for a patient to take part in this program, and it's really helped to improve access to a high quality physiotherapy option. So for those that are interested, I have these flyers at the back of the room that tells you a little bit more about the program, and also has a list of all the current locations of where this program is offered. And we're working closely with the THS to try to keep expanding public access to high quality programs like this one. Thank you.
Guys can join us back up on the stage, but Dawn, I've got a couple more questions for you actually, so I'll pass you back to the line. Now, from your extensive research on osteoarthritis, how important is physiotherapy in managing chronic pain, especially when it comes to improving outcomes?
Yeah, so we talked a lot earlier about multidisciplinary care, and in that one of the allied health professionals that we talked about is physiotherapy or exercise physiologists, and particularly for something like osteoarthritis, exercise is actually the best medicine that we have for joint pain. People who have joint pain can be fearful of movement, so it is important to have a health professional guide you in the exercises that are going to be right for you, that are going to be safe for you, and that are going to help to improve your strength and function and those sorts of things. So exercise and physiotherapy care is first-line care for osteoarthritis, and it should be something that everybody receives the first time they present to the doctor with joint pain.
Great. Now, before we move on to anything else, we're actually at a point where we've got some questions for the audience. So, over to you, audience. Has anyone got some burning questions for our lovely panel? Yes.
I'll have a go. There was a clinical trial at the Menzies Centre that I had to pull out of early because I needed dental treatment. But it was one of the Hobart rheumatologists who was looking at the back modic changes and trialling osteoporosis drugs for pain management of such conditions. Have you heard of any results from that?
Yeah, I can share those results with you. And so there has been some work to trial osteoporosis medications for osteoarthritis, with the understanding that osteoporosis is a bone disease, but so is osteoarthritis. And there was some data coming out from longitudinal studies, so not randomized controlled trials, but just studies where they followed people over time. And what they found was that people who were on osteoporosis medications, specifically the one that we were testing at Menzies was called zoledronic acid, had less severe pain over time and a lower risk of joint replacement. Since that time, a lot of studies, including the one I think that you were involved with, has found that if you randomize people to zoledronic acid or a matching placebo, pain improves by 30% in both groups. So it's not effective to improve pain, and an osteoporosis medication is no better than a matching placebo.
Yes, I was just curious because I never heard the final outcome because the trial was extended beyond what originally was envisaged. So I thought, well, maybe they're onto something, maybe they're not, but I never found out.
Yeah.
Okay.
Yeah.
So I think placebo in pain is a really interesting thing to talk about. So placebo in most studies is around 30%. In pain it is as well, but there's no placebo I can prescribe you. But we do know that it works, and this is one of the other reasons it makes trials difficult. So because pain has often a psychological component to it, we do know that if we give you something and we say this may help your pain, some people will respond to it simply because we've planted that seed. And so we definitely don't have a placebo on the PDS, but it would be nice if we could at times, because it is a risk-free way of being able to get some pain reduction in some patients.
You go to a pain specialist, Medicare won't give you a rebate. I bet no one knows that.
Looking at $300.
You're looking
Yeah.
at $300 to $350 a visit. You can't get a rebate.
Oh.
And that's through telehealth and some other doctors as well.
I'm sorry to
Yeah.
put that.
I don't have an answer for that one. It might be something due to the telehealth component, because I was pretty sure that seeing a pain specialist in Tasmania did make you eligible for a Medicare rebate. So yeah, that's interesting to know.
No, they both told me the same thing.
Did you have a referral?
They weren't sort of specialists, they were just doctors.
Yep.
I went to a pain specialist last week,
Expensive
and yes,
doctors.
I did get a Medicare rebate.
Oh.
Yeah,
It
and
might
so
depend on the provider.
it could very much depend on the provider, and I think as consumers and patients, we have to do our research on the types of doctors that we're going to see as well, because pain is big business. So trying to get recommendations from other health professionals or other patients who have seen reputable health professionals is really important too, to make sure that you are on the right path to see the right person for you.
Yes.
I've got scoliosis with a 65-degree col, and I've been told there's nothing I can do except wear a scoliosis brace, which I've had one for 2 years now, and it's not doing its job anymore. I've had to get a new one, which comes up under the armpits and up here, and I can't keep it on for more than an hour because the pain is so chronic, and I'm on 15 milligram Norspan, and I sometimes have to take a Palexia as well, and I'm always in chronic pain, and they say there's nothing I can do except wear this brace. I've had 2 radio frequency denervation treatments, and neither of them worked, and I don't know if there's anything that anybody on this panel knows which will help me.
Yeah, I'm happy to speak with you about it afterwards for a sort of a personal discussion. Most of the everything we've talked about tonight is quite general advice, but yeah, I'm happy to speak to you afterwards.
Yeah, I'll also, along with that, if you've got some personal questions about your pain specifically, it might be best to speak with a panel afterwards at the end of the evening. Yes.
Yeah, just a general question really, and I'll just use an example because I know of it. In terms of future therapies or things where we're looking at some things that have just come on the horizon, like you were saying, endometriosis, and the team-based approaches to these things. The bodies like this, I think it's called Endometriosis Australia and things like that, they seem to have only just begun and been funded. Are they working closely with drug therapies and physio able to look at a team-based approach to this management as advocates in this space?
So the federal government has funded that for delivery through the primary health networks. So the general practices are being funded to provide that. It is largely intended to be multidisciplinary. Yeah. So that's a sort of model, I suppose.
Yeah. I guess too that from what I understand, there aren't any drugs that work particularly well in that space.
No, there's a few drugs, as you perhaps know, but
yeah, just probably a question for after. I don't want to take up the time.
Yeah, again, it's very similar in a way, in that there's a focus on other factors. Again, the cognitive behavioural therapy, etc., is part of that, rather than just the drug therapy. Yeah.
All right. Well, there was one more. Yes. Sorry.
Just one more. As a health and fitness professional, I just wanted to thank you for advocating for multidisciplinary approach to it, and particularly to movement, as you came into and you spoke about physio and exercise physiologists coming on board. I hope the panel and anyone that you're involved with, you can continue to educate the professional in the group and the GP to sort of really work together. I'm part of Loss Fitness, so Australia Fitness, it used to be called before, so we are really strongly want to work with GP and physio just to provide as much relief as possible when people are in pain. So I thank you, and I hope you can continue to advocate for that.
Thank you.
I just wanted to ask, is there much any evidence yet about Botox being used to help neurological pain, nerve pain?
Yeah, there's some evidence.
Yeah.
There certainly is for neuropathic or neurological pain. There's been some trials showing some benefit. It hasn't really progressed a lot in practice yet, but there's some early evidence. That's been one of the sort of advances, if you like, the last couple of years. Yes. That's the advantage often of being long-acting, as you perhaps know, which is good.
John.
It sounds like you were alluding earlier that it's a multidisciplinary approach that's needed to managing pain. Am I right in assuming that that's going to happen through a dedicated pain clinic where you have all those disciplines together? Because it sounds like it's a bit hard to get a group of varied professionals together to manage an individual's pain, and that leads to the question: is the solution to that more pressure on government for more pain clinics?
Well, I'll go first, John. Dawn and Fee might have slightly different answers. I'll come from the primary care. This is back to the strengthening Medicare. So a lot of that, if you go back and look at it, what Minister Butler said a year or so ago, and where funding is meant to flow eventually, is about having it in the community, in the general practice. So the general practice is not just a GP, there are allied health, including physios, psychologists, pharmacists, others either there on a permanent basis or coming in and working there in the clinic. So the federal government has at least said that's their vision, that's what they want to see, rather than solo sort of general practitioners working on their own, etc. So to answer your question, I think one of the hopes is would occur in the community setting, but we're yet to see. They've only funded some minimal sort of pilots at this point, so we're yet to see the sort of fruition of that.
Yeah, there are some private pain clinics or pain facilities that are opening and being trialled as well, and ultimately I would really like to see more pain clinics being funded, and that's one way forward. But I think we also have to recognize that not all physiotherapists are the same, and physiotherapists as a profession would have a specialization or an interest in a certain area. And so if it is chronic pain that you have, it's important to seek a physiotherapist who has an interest and experience and long-term experience in treating pain. Same with psychology. Psychology is can be incredibly useful for people with pain, but certain psychologists have different specialty areas, so trying to find one who has the specialization in pain and even probably some extra pain credentials.
I think the other thing is timely access. So rather than necessarily, we do have a pain clinic in the south, but it's not timely to get into. So as we noted before, we know if your pain is acute, if we can manage it really well, we can help it prevent it getting worse. And it's the same with any condition. I mean, going to arthritis, people are on the wait list for many, many, many years, potentially waiting for knees and hips to be done. During that time, you can't necessarily see a pain clinic because you're waiting for surgery for that pain-related condition. So having it in general practice means that you have that more instantaneous, more easily accessible management, which means that hopefully we can get on top of the pain before it continues to progress, rather than waiting until we're at that end stage and we really are at a point where there's very few options left. So I think it's very much about timely access, and therefore the more clinics we have or the more GPs participating, the more ability that we have to be able to sort of manage this before it gets too bad and we can't step it back.
Great.
And another question on the GLAD program. You referred to a 6-week program. So is that one exercise program for 6 weeks and then you cease, but there's pain relief for 12 months afterwards, or is it ongoing exercise?
No, that's right. So the program's been evaluated over a 3-month and a 12-month period. That's a standard evaluation time that the GLAD group set up. So it's an online registry. So any patient who enters into the GLAD program completes the questionnaires to contribute to the registry and the data so they can continue improving the program. But as you said, the program does only run for 6 weeks. So it's 6 weeks, twice weekly exercise. And if we think about a drug, if you had a headache and you had 1 Panadol, maybe that's not the dose that's going to work for your headache. What GLAD is it's the right dose, it's the right type of exercises, it's the right education and communication with patients. So it really enables them to come out of the program feeling like they can take on things that they haven't been before. So the program has shown that it improves physical activity levels up until 12 months. So I think that's why we continue to see those pain benefits. And another part of the program is that throughout the 6 weeks, they're making sure that you're doing the exercises correctly, but also guiding you into a program to start doing them at home. And many people will continue doing their exercises at home, or at least they tell us, oh, I stopped doing my exercises and my knees started hurting again. So I did them, I'm back doing them twice a week, and I'm under control again. So, yeah.
There are other programs out there, but you really do need to seek them out. I've just gone on a 12-week program with an exercise physiologist in a class setting, and he individualises the exercises for my situation. And he does an assessment at the start and at the end, and it's government funded, so it costs me nothing. And,
that's excellent.
You've got to seek them out. I read about that one in the Mercury.
Yeah. You do. You have to advocate for yourself. Absolutely.
All right. Well, thank you everyone for coming along this evening, and thank you very much to our very informed panel tonight. You were absolutely fantastic. Your knowledge is second to none. I hope everyone learned something tonight. Thank you to St Lukes for having us, and our other sponsor, AbbVie. Obviously, we thank you everyone for coming along and showing your support at the foundation. We put this event on at, for free for you, so if you do feel like you got something out of tonight, please feel free to make a donation on the foundation's website. That's rhhresearchfoundation.org. And thank you all once again, and we hope to see you at another event soon.
Thank you.